All right, let's jump right into this explainer. Today, we are breaking down what is absolutely one of the most terrifying clinical presentations in neonatal medicine, a severely hypoxic newborn. We're going to map out persistent pulmonary hypertension of the newborn, or PPHN, step by step. We'll look at exactly why it happens, how we spot it, and how modern medicine fights back. Here is our roadmap for the discussion. First, the first breath. Second, when transition fails. Third, triggers and risk factors. Fourth, modern treatment strategies. And finally, long-term outcomes. Okay, part 1, the first breath. To really grasp the hypertension aspect of this disease, we have to remember that high pulmonary pressure is actually completely normal before birth. Inside the womb, the lungs are basically inactive, right? Because the placenta is doing all of the gas exchange for the fetus. Since the lungs aren't needed for oxygenation just yet, pulmonary vascular resistance is incredibly high. It basically acts like a closed door, forcing blood to bypass the lungs entirely through two anatomical shortcuts, the foramen ovale and the ductus arteriosus. This sends all that precious oxygenated blood straight out to the rest of the body. But then the moment of birth happens, and it triggers this precise rapid-fire sequence. The infant takes that crucial first breath, and the lungs expand with oxygen. This sudden oxygenation of the pulmonary vascular bed is like flipping a master switch. It causes that high pulmonary vascular resistance to just drop dramatically, and blood immediately rushes into the lungs. That sudden shift in pressure functionally closes those anatomical fetal shunts we were just talking about, allowing the baby to breathe normally and independently. It is literally a spectacular physiological pivot. Moving to part 2, when transition fails. Normally, extrauterine life brings low pulmonary pressure, and the lungs do their job perfectly. But in PPHN, the newborn gets trapped. They're stuck in a state of persistent fetal circulation. The vascular resistance stays stubbornly high, and because the pressure in the lungs remains higher than the systemic blood pressure, the blood just keeps shunting right to left. It completely bypasses the lungs. The result? Severe refractory hypoxemia, which means their oxygen levels stay dangerously low, and it honestly doesn't matter how much extra oxygen you give them. And the scale of this emergency is critical. Overall, PPHN occurs in about 1.8 per 1,000 live births, so it's rare, but it's highly lethal. Interestingly, though, while we almost always think of this as a term infant problem, the incidence is actually way higher in late preterm infants, spiking up to 5.4 per 1,000 live births. Which brings us to part 3, triggers and risk factors. Structurally speaking, we can drop the causes of PPHN into 4 distinct buckets. First is maladaptation. This is an abnormal response, usually due to lung diseases like meconium aspiration syndrome or pneumonia. Second is underdeveloped vasculature, which you'll see in conditions like a congenital diaphragmatic hernia, where the lungs simply haven't grown enough. Third is idiopathic, where the pulmonary vessels are just inexplicably thick and muscular. And fourth, intravascular obstruction. That happens when the blood is too thick or viscous, like in neonatal polycythemia, which creates a literal roadblock to blood flow. But we also have to look upstream at the pregnancy itself, because the prenatal environment plays a massive role. Things like maternal diabetes, obesity, smoking, and infections like chorioamnionitis can significantly elevate the risk. We also see strong associations with certain medications taken during pregnancy, including NSAIDs and specific selective serotonin reuptake inhibitors, or SSRIs. Actually, looking closely at the data from systematic reviews, maternal use of SSRIs, or SNRIs, past the 20-week mark of gestation carries a 2.08 odds ratio for the development of PPHN. That statistically observed jump in risk is a really critical piece of the prenatal history that clinicians absolutely have to gather upon NICU admission. Now, within that class of medications, it's worth pointing out that they don't all carry the exact same risk profile. The data indicates that sertraline ranks as having the lowest risk for PPHN, mostly because a lower percentage of the actual drug physically crosses the placental barrier compared to the others. Let's look at part 4, modern treatment strategies. Before you can treat, you obviously have to confirm the diagnosis. We look at clinical signs like severe cyanosis and blood gases, sure, but we also lean heavily on biomarkers. Brain natriuretic peptide, or BNP, is a hormone produced by a highly stressed right ventricle. If you see a BNP level shoot over 550 picograms per milliliter, that is a huge predictive indicator that the newborn is dealing with PPHN.
But honestly, the ultimate detective tool here is the echocardiogram. Neonatologists run through a super meticulous 7-step evaluation process. They use the ultrasound to directly visualize the right ventricle's dilation, measure those pulmonary artery pressures, assess the shunting, and crucially, they use it to rule out structural congenital heart defects that might just be mimicking PPHN.
When it comes to treatment, it's a very strict escalation ladder. You start off by optimizing lung volume with oxygen and mechanical ventilation. If there's underlying lung disease, you give surfactant to help those air sacs stay open. Then you bring in the real game changer, inhaled nitric oxide. It's a potent gas that specifically relaxes the pulmonary blood vessels. If the baby doesn't respond to that, we step up to targeted intravenous vasodilators like Sildenafil. And finally, for the absolute most severe refractory cases where the lungs just refuse to work, the ultimate rescue therapy is ECMO. It's essentially a heart-lung bypass machine that takes over outside the body, giving the newborn's lungs the time they need to recover.
And finally, part 5, long-term outcomes.
So, survival rates have improved drastically thanks to interventions like inhaled nitric oxide and ECMO, but the outcomes can still be pretty sobering. Anywhere from 10 to 30% of PPHN survivors are going to face long-term neurological, developmental abnormalities, cognitive delays, or hearing impairment. That severe lack of oxygen in those first few days of life really does leave a lasting footprint.
The recent Neurophone study kind of hits the nail on the head regarding why understanding this timeline matters. They concluded that survival is really just step one. Because of the high prevalence of neuropsychomotor disorders, these kids need dedicated, multidisciplinary follow-up for years. We can't just treat the acute crisis in the NICU and call it a day. We have to screen for and actively manage those developmental ripple effects as they grow.
So, having mapped out this whole pathway, from that critical physiological pivot of the first breath, through those intense life-saving NICU escalations, to the reality of the long-term risks, I want to leave you with a thought. As our acute medical technologies get remarkably better at saving these infants right at birth, how do our healthcare systems need to evolve to actually support the lifelong journey of these resilient survivors? Thanks so much for exploring this with me today on The Explainer.